So good morning, thank you very much. It's a pleasure to be here. I would like to thank the organizers for inviting me, just to get familiar with this. Okay, so, yeah. So I think that the capacity of our hospitals to attract patients from other countries will largely depend on the attractiveness of our country in terms of quality of health care. And I think that this goes beyond the generic statement, and it will become increasingly important, critical in the next years due to the fact that medicine is radically changing due to an ongoing revolution, the so-called personalized medicine. And the implementation of personalized medicine requires interventions at the level of the nation, nationwide programs. And I have the impression that our country is going in that direction. And in the next 10 minutes, I would like to comment on this. So, okay, here I reported two examples, the first and the last, of how personalized medicine is changing medicine. And I will refer to oncology, which is my field of interest. On your left is an invariably fatal leukemia that now is cured using personalized drugs without using chemotherapy. And that's the first example, late 90s. And on the right is the last example, a couple of years ago, and is immunotherapy with checkpoint inhibitors, which shows the obtaining of prolonged remissions in metastatic melanomas, which is a typical not curable type of cancer. Critical to the implementation of this type of therapeutic interventions is the availability of biomarkers. So I'll give you the most typical example, which is that of providing this type of treatments to patients. You can cure that type of leukemia with that type of drugs only if the patient, that specific patient, has a specific biomarker. In that case, is an altered gene. So the drug is coupled with a marker which allow for stratification of the patient. Biomarkers are critical to the implementation of personalized medicine, not only for selecting the patients which can be cured with those drugs, but also to identify patients which have hereditary tumors, such that you can then map in the family's risk of cancer, and also monitoring of the disease and others. Among all the biomarkers, the most useful right now, which are the first to enter this new era, are the genomic biomarkers. So basically the sequencing of the patient tumor DNA and the patient DNA in order to identify those flags which allow, for example, to identify the right drug and to map the risk of cancer. There are, however, a number of big problems, not in Italy, worldwide, for extending the benefits of precision medicine to all patients. The first one is that the number of patients which can actually access these benefits is much less than the ones that can access in principle. In other terms, only a fraction of the patient which could benefit of personalized drugs are indeed treated with those drugs. And this is due to a number of things, such as the fact that we don't have screening abilities for the entire cancer population. If you don't screen the genome of the patients, you don't know which patient to treat with what. It is considered that only 10% of the patients which could access a drug, which is available now, actually do it. And then there is a more general problem, which is the fact that the number of patients that today can access those drugs in principle is low, less than 10%, because we do not have enough drugs for all the cancer types. And that can only be resolved in one way, that of opening to the patient access to the pipeline of drugs which will become available in the next years. In other terms, allow the patient to enter clinical trials as a mechanism for the patient to access innovation in oncology. So here I put these 3 bullets for giving the opportunity to our patient to benefit today of what this revolution is providing in terms of healthcare. We should allow those patients to be screened. We need to sequence the patients. We have to have access to the available drugs, the ones which are already approved. And third, we have to allow our patients to access clinical trials in order for them to be treated with a pipeline of drugs. Clearly, none of our hospitals can by itself resolve this type of issue. And this is a general issue in the world, how we can put together efforts in order to allow access of the patients to the available knowledge and access to the patient to the ongoing innovation. And I think this can only be done at nationwide level. And this is, I guess, what Italy is doing right now, which is an important point for us, for our hospitals to become attractive worldwide, because this is not an Italian problem, this is a worldwide problem in personalized medicine. I just briefly mention in 2 minutes to the effort which is ongoing in this network of hospitals, which is called Alleanza contro il Cancro, which is a network of 21 institutes which are recognized by the Ministry of Health as of national interest, so-called IRCs. And the Ministry of Health is on top of this network, which involves another 70 clinical centers, so a lot of patients. We're talking about 90,000 new cancer patients per year, with 70,000 patients in clinical trials. So those are figures of the 2014. So within this network, what is happening is that we are organizing national screenings. In other terms, all the patients which access this hospital will be, this will start very soon, in next month, will be screened genomically for the genome, the DNA of the tumors of these patients and the DNA of the patients will be sequenced. Again, this can only be done at national level for the mobilization of the resources that you need for that. And this would allow 2 things for each patient. First, to map which genes are altered in their specific tumor to identify which type of drug is good for them. And second, if they have genes that expose their family to the risk of getting cancer. So mapping the best treatment and mapping the risk of cancer in the family. So, sorry, how can I go back? This is to go back. The one that. Yeah. Just to give you an example on the clinical power of this type of screenings, you know very well that a large fraction of breast cancer and ovary cancer are indeed hereditary. So basically, there is a risk in the family that we need to know in order to save life in the relatives. But very little for the other type of tumors. However, if we screen all the genomes in all the patients, the potential is something like 10% in the stomach, 10% in the prostate, 10% approximately in the lung, and so on. So a very large fraction of patients might allow their family to be investigated in order to prevent hereditary tumors. And that's the value, instead of analyzing the genome of the cancer of those patients, and I'm almost finished. So basically, the total of the number of drugs which are linked in terms of efficacy to specific genetic alteration is around 500, really a lot. And if we look how many patients we can treat with this 500, it's a lot. If you remember, I told you that only 10% can be treated with drugs which are today FDA approved. But if we consider the entire group of drugs, so we enter into clinical trials, we go up to almost 80% of the patients today that could be treated with drugs, which increase substantially their probability and their possibility to get cured. So with a simple genetic screen, we offer to the patient entering the available drugs and entering the available research. And that's the conclusion of this approach. And this is taken from my institute, the European Institute of Oncology. Once you have the definition of the genetic portrait of the tumor, then you can provide drugs within clinical trials. This is an example of, in our institute, of drugs, personalized medicine drugs, which can be administered to patients based on their genome. So in conclusion, what I think is important is that our country tackle the big issues of personalized medicine today, which is access of the patient to innovation at the national level, and I think this will increase a lot the attractiveness of our hospitals. And I thank you for your attention.